السلام عليكم. كل سنة وحضراتكم طيبين بمناسبة رمضان الكريم، وبنشكر الجمعية القلب المصرية على دعوتها النشاط العلمي اللي موجود في رمضان، وده يعني حاجة مش جديدة على الجمعية. ال topic of today will be the multimodality imaging of the right ventricle. As we all know that multimodality imaging has drastically improved the understanding of the right ventricular anatomy and function. And echocardiography represents the most widely available tool to assess the right ventricular function, though its limitation in evaluation of the right ventricle are well described. The innovation and the rapidly growing CMR and CT offer volumetric assessment of the right ventricle with high spatial resolution. The problem with the right ventricle is in its anatomy and function. The right ventricle is a complex crescent shaped. It's wrapped around the left ventricle through the inflow and the outflow portions. The right ventricle is composed of three distinct anatomical regions. It includes the inflow tract, the body, and the outflow tract, and it resembles like a clam shell that's around the left ventricle. And it's exactly, we can describe it like a clam or a crescent. This is another anatomical three-dimensional reconstruction of the right ventricle filling around the left ventricle. We can see here how strange and complex the geometry of the right ventricle in relation to the left ventricle can. Right ventricle is distinct from the left ventricle in many aspects, including that it's more apically displaced tricuspid valve of the septal leaflet. There is a moderated band in the right ventricle that's more prominent. We have three or more papillary muscles. With the left ventricle, we only have two. We have the tri-leaflet tricuspid valve, and there's coarse trabeculations with thinner wall and mass. It's constitute about 1/5 of that of the left ventricle. The right ventricle myocardium is made up of two layers. The subendocardial layer of longitudinal fibers that result in systolic contraction of the base toward the apex, with also there's a superficial circumferential layer of the fibers responsible for inward contraction. But the right ventricle predominant motion involves longitudinal shortening. This is the main motion of the right ventricle is longitudinal, plus there is some evidence of systolic descent of the basal portion of the free wall toward the apex. Also, there is a peristaltic contraction from the inflow to the outflow portions of the right ventricle. And unlike the left ventricle, twisting and rotational motions don't contribute significantly to the right ventricle contraction as it does in the left ventricle. So we have some challenges in imaging the right ventricle, that the right ventricle is crescentic in shape, and unlike the left ventricle, it cannot be characterized using simple geometric assumption that we use in the left ventricle. And the right ventricle has three distinct anatomical components: the inlet, the body, and the outlet. And these three components of the right ventricle cannot be simultaneously imaged in a single 2D plan by echocardiography. So we image one or two parts in the same sector, but we cannot see the three parts in the same sector of the 2D echocardiography. Also, the right ventricle retrosternal position result in difficulties with ultrasound wave transmission, and linear dimensions and area can differ markedly with minor rotation of the transducer during the echo acquisition because of its proximity to the probe. And the extensive trabeculations result in difficulties with image analysis, leading to variability in reproducibility and the accuracy of assessment by the echocardiography. And marked load dependence can also lead to variation in shape, size, which can lead to day-to-day variations in volume and ejection fraction, especially that the right ventricle has a thin wall and accommodates more fluid and change in load rather than the left ventricle. And this image enumerates the differences or the challenges in the assessment of the right ventricle. We can see here the proximity of the right ventricle to the probe and the difficulty to include all the parts of the right ventricle in one sector of the 2D imaging. The use of multimodality imaging in the right ventricle enables better evaluation of the volume, shape, mass, and tissue properties, and the emergence of additional techniques, including the strain using the speckle tracking and three-dimensional echo, as well as CMR and CT, allow for even better characterization of the right ventricle. The CMR is currently considered the reference standard for evaluation of the right ventricle. It's now considered the gold standard for the assessment of the right ventricle, including the size, the geometry, the systolic function, and even the volumes. When echo assessment is inadequate and CMR is unavailable or unsuitable, the CT is also used for quantification of the right ventricular assessment. And you can see from this table, it's comparing the different multimodality imaging in the assessment of the right ventricle, including the systolic function, the volumes, the tissue characterization. We can see here that the CMR is super in the tissue characterization, volumes, and systolic function, but still the hemodynamics is better by 2D echocardiography. So we have echocardiography, we have the CT, we have the CMR. We will start by reviewing the assessment of the right ventricle by the echocardiography. We can assess either the size or the function. The size, we can measure the linear dimensions, and the function, we can use either the 2D or the 3D methods. So let's start by the linear dimensions. You can have here the right ventricular proximal dimension and the distal dimensions below the RVOT. Also, we have the linear dimensions from the apical forward chamber view, RV focused view. You can measure from here the mid diameter, the basal diameter, and the longitudinal diameter. And you can measure from the subcostal view, you can see the wall thickness of the right ventricle from the subcostal view. Moving on to the assessment of the function by echocardiography, we have some 2D and Doppler methods for assessment of the function, including the TAPSE, the peak systolic velocity by the tissue Doppler of the lateral annulus, and the fractional area change. We trace the right ventricle in the apical forward chamber view in the end-diastolic and end-systolic area, and we put this in a calculation to get a change, the percent of the change of this area. And this is examples of the normal fraction area change, and this is a borderline fraction area change, and this is impaired fraction area change. Also, there's another parameter that's called the myocardial performance index. We measured it from the RVOT velocity, and we exclude from this the IVCT and the IVRT and put this in an equation to get a number at the end of this. And this is the cutoff values for the functions by the echocardiography, including the TAPSE lower than 1.6 or 16 millimeter is abnormal, systolic velocity less than 10 by the tissue Doppler, a myocardial performance index more than 0.4, and the fraction area change less than 35, all considered abnormal by the echocardiography. The new and coming is a strain of the right ventricle, where we can measure the myocardial strain of the RV free wall. And also we have a new software that's dedicated for the assessment of the right ventricle by the 3D echocardiography. And it's there's now some machines that have a dedicated software for this measurement, and it's considered to be comparable to the CMR. It's reasonable correlation between the volumes and the ejection fraction measured by MRI and 3D echocardiography, and it tends to underestimate the volume by 3D echocardiography compared to the MRI and CT is well established. Also, you can measure the pressures here by the echocardiography, including the peak tricuspid flow velocity, and adding to it the IVC parameter, the right atrial pressure, and here you can calculate the right ventricular systolic pressure and the pulmonary artery systolic pressure. Also, you can, using the PR gradient, to estimate the mean pulmonary artery systolic pressure and the end-diastolic pressure. Moving on to the CT as the second multimodality imaging of the right ventricle. The CT functional assessment of the right ventricle is performed using retrospective ECG gating to provide dynamic images throughout the cardiac cycle for quantification of right ventricle volumes and function. And this method required increased radiation exposure because it's CT, and also it requires exposure to iodinized contrast. And CT, like CMR, provide multiplanar images of the right ventricle with excellent endocardial definition and high spatial resolution. And this is examples of some of the images came from the CT. You can see here, you can measure the volumes accurately, and you can constitute an ejection fraction from these volumes. And while CMR is traditionally used for more frequently and for quantification of volumes and ejection fraction, CT can be used as an alternative modality when CMR is contraindicated or unavailable. There is the advantage of CT also that you can assess the pulmonary arterial vasculature as well as the lung parenchyma, and thereby provide information regarding the pathophysiology of the RV dysfunction and its sequelae. And CT can also provide assessment of tissue properties, including identification of myocardial replacement with fat as seen in arrhythmogenic right ventricular dysplasia. Like this example here, you can see here there is the fat deposition in the right ventricle, and you can see here clear the right ventricle is dilated, and also the right ventricle is systolic function is impaired. The parenchymal lung findings with chronic obstructive pulmonary disease and interstitial lung disease can also be idiopathic or secondary to connective tissue disease or sarcoidosis is observed in the patient with group 3 pulmonary hypertension. Also, you can see from the CT, you can see that if there is pulmonary nodules, extracardiac shunts, bronchial and vascular abnormalities that can also readily be seen by the CT. The pulmonary artery diameter cutoff for identifying pulmonary hypertension ranges from 25 to 33 among 12 studies that include patients from different pulmonary hypertension group, and the dilatation of the main pulmonary artery and the main pulmonary artery to descending aorta diameter more than 1 is highly indicative of pulmonary hypertension. We can see here there is aneurysmal dilatation of the pulmonary artery in comparison to the aorta. You can see also its implication on the right ventricle. The right ventricle is dilated and compressing the left ventricle in these images. Also, you can identify patient with pulmonary hypertension to do chronic thromboembolic pulmonary hypertension. You can see organized thrombi within the pulmonary vasculature. This is the advantage of the CT over the CMR, and typically show large bronchial artery collaterals, right ventricle enlargement, irregular vascular wall thickening, with thrombi filling defects that may complete or partial eccentric or even calcified. Like this image, you can see here there is some filling defects seen in a patient with history of pulmonary embolism 6 months ago. The limitation of the widespread use of CT are due to use of nephrotoxic contrast and iodinated radiation and limited accessibility as compared to echocardiography. The last modality, and it's considered now the gold standard for assessment of right ventricle, is the CMR. The CMR is known to provide valuable prognostic information for the right ventricle with accurate quantification of right ventricular size and function. It's considered now the gold standard, and also it has the advantage of the right ventricle tissue properties assessment. In case of pulmonary hypertension, the late gadolinium enhancement at the RV insertion point has been shown to provide risk stratification for morbidity and mortality, and plus the impairment of the ejection fraction of the right ventricle, as we see in these images. Also, the late gadolinium enhancement at right ventricle has been associated with more advanced disease and poor prognosis of pulmonary hypertension. The right ventricle volumetric and functional assessment is important in a wide range of congenital heart disease. For example, the right ventricle functional indices are used for assessment of pulmonary valve replacement in patients with repaired tetralogy of Fallot, with the proper assessment of the volume impact of the PR that occurring after the repair. In patients also with arrhythmogenic right ventricular dysplasia, CMR indices are critical components of diagnostic criteria, which include CMR-derived right ventricular ejection fraction and end diastolic volume. Like these images, you can see massive fatty infiltration of the RV free wall. So my take-home message is the right ventricle function and the pressure are important prognostic, morbidity, and mortality factors in many cardiac diseases. Proper RV assessment is crucial for risk stratification and decision-making, and multimodality imaging of right ventricle is frequently required, especially when echocardiography is not conclusive. And knowing the pitfalls and indication for each imaging modality of the right ventricle is your way to proper management. And thank you for your time.